I would like to thank the organizers for giving me the opportunity to talk to you about an issue which I think affects all domains of biomedicine, and I'm quite sure that this is also true for pediatric endocrinology. It also affects, I think, all professions in medicine, and that is if you're in academia, if you're in industry, or if you're in private practice. You have heard it, this is my disclosure statement, and in fact, part of my disclosure is that I have been in the business of doing translational research for quite a long time, and many people would say quite successfully, but I doubt it, and this is not a joke. I really seriously have problems in finding where I measurably contributed to improving the life of patients with stroke, although I'm a translational stroke researcher. And you also now have kind of a motivation why I think about those things and why I think many of us should do that. Now, actually, there should be reason to celebrate, obviously, because we are making progress in medicine. There's no doubt about that, and I just have two examples for you. You all know them. One is CRISPR technology, which ushers in, I think, an area of potentially of gene editing and completely novel therapies. And that is also true, for example, for CAR T-cell therapy. If you think about it, this is at the verge of being relevant to many types of cancers that may even become curable. So this is certainly great progress. There is also, quantitatively, there's extreme proliferation in all fields in terms of outcomes. I just checked Paediatric Endocrinology in PubMed as a term, and as you can see, your field in terms of paper output is growing exponentially. And in fact, we are finding what we want to find in our studies. So in these publications, this is from a meta-analysis that looked at many different domains in science, actually also obviously in medicine. And in clinical medicine and in some and in most of our experimental fields, lo and behold, 80%, sometimes 90% of the studies find what they are trying to find. Now, this is actually, to me, already a sign that there may be a problem. So let's just briefly ask, are there signs that we could be in trouble? Now, you all know that translation, so this trajectory that comes from discovery, from exploration, and eventually leads to guidelines, to novel and effective treatments, is a very protected one. It's also one that has a tremendous amount of attrition, and it takes a very long time. So that is actually already a matter of concern. So is this the way it needs to be, or are there some inefficiencies in this process? Now, you may have heard this term of lost in translation, which basically, if you go through the literature for any field, you will find reviews that review all those failures. And this is despite the fact that you also lead lots of papers that announce breakthroughs in treating cancer and treating Alzheimer's and so forth. But lost in translation, I think, is kind of a ghost that haunts many of our fields. There are other signs that there may be something problematic going on, and it was in fact the industry that blew the whistle on a problem that they were experiencing, and that is they were trying to replicate pivotal findings of academic laboratories to license those findings in to produce drugs from it, and they were very surprised not to be able to reproduce many of them. Now, some people have argued that this is industry, and our worst postdocs are going to industry, so they cannot replicate what we do in academia. But this is, of course, not the case. And we know this now from systematic replication studies, which are still scarce, but they are going on. And for example, there is one that's called the Reproducibility Project Cancer Biology, which is in a very systematic fashion and, if possible, in collaboration with the original authors, trying to replicate top or key findings in cancer biology, all of them published in Nature, Cell Science, and so forth. Now, the project is not completely finished yet, but I think 14 or 15 of those replications have been done so far. They are all published in the journal eLife. All of them are pre-registered at the Center of Open Science. And to summarize the results so far, it doesn't look very good. In fact, in many instances, replications were not even possible because the information in those papers was not enough to come up with a decent experiment to replicate it, and the authors were unwilling to share this information. Where full replications could be attempted, in a portion, let's say 20 or 30%, the finding was replicated, but at a much smaller effect size. So there was an effect in that direction, but not of that size. And quite a proportion, the finding didn't show up again. So here we're talking about the key findings of cancer biology. And in fact, this is one reason among many, I guess, why many researchers feel that we are in a kind of a reproducibility crisis. This is from a survey that was done by Nature. And in this survey, more than 50% of the queried researchers were actually under the impression that we are in the midst of a reproducibility crisis, a severe one, and 40% still thought there is one. Maybe it's not that important, but there is one. So there is a growing concern that we have a problem here. Now, what are the reasons for this? I mean, there are many reasons, and it's just damn complicated, and biology is complicated, and clinical trials are complicated. A lot of the low-hanging fruits have been picked, so the effect sizes in many of the things that we approach may be actually rather smallish. But there are things that we can single out that seem to be avoidable, but they are actually rather prevalent. And what I'm showing you here is just one example. This is from a meta-analysis done by Malcolm McLeod's group. He was looking in this meta-analysis at thousands of papers in different domains. Most of them were in neuroscience, one is from cardiology, and each bar that you see here represents papers or studies in certain disease fields. SCI, for example, means spinal cord injury, or glioma is obvious, focal cerebral ischemia, that's stroke, AD is Alzheimer's. And what you can see is the prevalence of the reporting of, you might argue, standard ways of reproducing or reducing bias in those preclinical. These are preclinical experiments, mostly on rodents. And as you can see, less than 30% randomized, roughly 30% blind. Almost no one does sample size calculations, and it's very rare to find conflict of interest statements. Now, this is a paper from 2015. You may argue this has changed. In fact, there is a slight change. There are some other publications right now going into different domains of preclinical science, and the highest numbers I could find for any of those categories was 40%. So this is not the majority. Now, this is not happening only in preclinical, and this is just an example I brought to you because it was published 2 days or 3 days ago in the British Medical Journal. And it points to the fact that in clinical research, in fact, in pivotal clinical research, in studies that lead to FDA approval of, in this case, cancer drugs, there is tremendous bias, there are inappropriate study designs, and there are problems in reporting. This is quite a shocking finding that in this case, I think, points to a problem in the cancer field, but there are reasons to at least be suspicious that we might see things in other fields as well. Now, there are other problems in clinical medicine, and this is a study that we did. It's a study that was recently published, and where we were looking at the timely publication of clinical trial results of German university medical centers. So these are investigator-initiated trials that are sponsored by the medical university. So in Germany we have 36 of them, and what you see here is they are lined up, and they are sorted by the percentage of published results within the World Health Organization time frame for a timely publication, which is 2 years after you have finished your study. And you can see the mean of this is 40%, so 60% are just not out there. You can also see that some are better than others, but in principle they are all bad. Even if you look out there at, let's say, 5 years or 7 years, you will find that still 40% are not published, and it's very likely that they never get published. Now, sad news, in fact, is that we are in German medical universities are in good company, because there are online resources like the EU Trials Tracker or the FDAA Trials Tracker. And they actually come up with the same numbers, and these then include industry-sponsored studies. And so, lo and behold, roughly 40% of clinical trials never get published. So I guess you have to digest what this means. I mean, we include patients into trials, telling them that the knowledge that we gain from them will help others, because probably the study medication we don't know. Also, they may be in the placebo arm. So this is altruism of our patients, and this information never gets out there. So what I'm doing right now, I'm sort of collecting evidence that the system is obviously not working optimally. So and I think, and I could go on, I could show you much more, but I think there is evidence that we have a problem. Now, there are certainly many reasons for those problems, and what I would like to mostly focus on is bias. So bias, I guess a simple definition is that it's subjective reality that we inform by our own prevalences. And I've shown you that in preclinical, I've shown you some numbers. It's rather rare that people are, or that researchers, I shouldn't say rare, it's not the majority that researchers are actually have measures in place to control those biases, like randomization, blinding, and so forth. Now the question is this relevant? You could argue, well, maybe they don't do it, but it's not really relevant. There is plenty of evidence that this is relevant. I just show you one little piece of evidence here from an own study where we looked at one drug in neuroscience. It's a stroke drug. There was a number, actually a lot of preclinical studies on this drug. And this allowed us to look at papers that, in this case, blinded their study and papers that did not blind it. And as you can see in this graph, the effect size, which is a very robust one, in this case, reduction in infarct size in those animals, is less than half if you control for this particular bias. And this is just one bias. That's kind of a detection bias that's in there. So there is plenty of evidence that not controlling biases contributes to overestimating effect sizes, potentially even getting false positives. Now here's just another example for a type of bias that is not very often talked about, but I think it's equally important, and it's called attrition bias. So this is from a study where we looked into the stroke literature, preclinical, but also in the cancer literature. And we were asking the question, do the numbers match up of those animals that go into a study and those animals that are shown in the tables, in the graphs? So do they match? we were shocked to find in 70% of the papers, and this was quite a sample that we had, and it was representative for a large part of the literature. In about 70% in both fields, we could not even answer the question because the authors didn't tell us how many subjects they were studying. And actually, in a lot of those cases where they told us, in the remaining 30%, there was a discrepancy. So animals were kind of missing. They went into the study, but then they didn't show in the results. In some cases, this was an explained attrition. That's okay. But in others, and in the majority of those, it was not explained. I'm quite sure you are aware of this, because if you read the literature, especially the experimental literature, you very often read, in fact, we found in 80% of the cases, you find asymmetric group sizes, like they report n equals 5 in the control and 7 in the verum group. Where have these two animals gone that are more or less in one of those groups? It's not explained. And there's a reason to believe that most start with the same number, because that would make sense. So there is attrition bias, and we may ask, where did those animals go? Now, there's another problem, and that's called, one could call it low sample size bias. If you're not in experimental medicine, you may not be aware of this. Sample sizes in those preclinical studies are exceedingly low. In fact, if you do a systematic review on it, you will find that, and there's very little variation between fields, the mean group size is 8. And the mean statistical power, again, with some variation, some fields have 60, others have 20, is less than 50%. You have to weigh in the fact that if you throw a coin, you have a power of 50%. So what this means is that, and it's very simple, it's kind of undergraduate biostatistics, that you can easily calculate that there must be a false positive rate in the literature that is roughly 50%. And even if there are true effects, they are overestimated by approximately 50%. There's actually quite a number of studies on this. It's called meta-research as a field, and it's growing. There are lots of things to study. And this is from a huge analysis that kind of with text mining went into the literature and looked at whole fields, in this case medical neuroscience and psychology. So these are hundreds of thousands of studies that went into this. And what they found is that indeed the degree of freedom, which is basically sample sizes, and this is now clinical and preclinical lumped together, this is kind of the whole literature, is exceedingly low. So if you just take neuroscience, that's my field, in 80% of the literature has sample sizes that are just a little bit larger than 20. If you go into medical, meaning sort of there we are in the clinical domain, but lumping fields together, you are still at a sample size of around 60 to 80. 80% of the studies have sample sizes that are lower. And this means that the power to detect small effects, and I think the biology dictates that most effects that we're after are small effects, is very low in all those fields. Now, if you add on top of this the problem of publication bias, and I'm sure you're all aware of this. In fact, in clinical medicine, this is well known. And part of the publication bias I already in a certain way alluded to, because I mentioned that 40% or so of the studies never get published, and that those that get published, 80% or so are positive, or 90% are positive. So if you do the math, or if you think about it, that already somehow signals that there must be something missing. And it's probably more the negative stuff that's missing. But this is actually also true, or even more true, in preclinical. That is, not many people are not aware of this. This is from a meta-analysis, again from Malcolm McLeod's group. And each point on this funnel plot is a study. And they were systematically looking at more than 500 studies in this field. And only 10 publications, that's 2%, reported no significant effect on the main outcome. This is amazing. I mean, so in other words, just in brackets, we can treat animals and it's great. But these are all neuroprotectants that were tested, but there's not a single neuroprotectant that we can use in the clinics. Now, if you then do something like this, and that's a funnel plot to try to see, do we have evidence that there is non-published literature of an effect that is counter the main effect, then this is what you get. You can impute it. This has been done here. It's a very conservative method. And you can show, in this particular study showed that at least 30% of the effects that are reported, 30% of the effects must be overestimated because the literature that exists but is not out there, which has effects that are lower than what was reported. So there is substantial negative publication bias in the literature. Now there's another problem which I'm not sure, I definitely have to say I'm not sure about pediatric endocrinology. I cannot tell you anything about it, but I can tell you that in my field, stroke research, where we mostly study male juvenile rats of a few strains that are raised under so-called specific pathogen-free conditions, that's like 95% of the field. Hundreds of thousands of mice and rats of that type are used. If you extrapolate what this would mean as a human cohort, you end up with healthy pubertal male twins that you raise, let's say, on 6 square meter isolator tents, and you feed them day in, day out with granola. That is certainly not characteristic for our stroke patients. You may be, and I'm not joking, this may be a bit closer to pediatrics. I mean, maybe this is okay. And there is pediatric stroke, so, but most of our patients are not pediatric patients, and the conclusions that are drawn from these results are actually meant for adults. Now, Now, this extends to the problem of the immune status. So I mentioned that they are raised under so-called SPF conditions. This means these animals have completely immature immune systems, even if they are aged. If you look at mice that come from a pet store or that you catch in Vienna on the street, they have completely different immune systems, and they are very much like adult humans, but we don't study them. So the typical recipe for a preclinical study right now is small data, small sample sizes, siloed investigator, just one group, not very stringent alpha levels, no registration, no data sharing, no replication. So let me finish off with, not to get too depressed about this, I think the good news is most of these things are remediable. And so what can we do? And I can flip through it because it's so obvious. It's so obvious what we can do. First, we need to increase internal validity. That means we need to randomize, blind, and predefine in-exclusion criteria. That's cheap, and we should do it. A bit more complicated but necessary, I think, is to increase sample sizes. This is actually now also demanded by funders, for example, in the UK. We can increase external and construct validity. We can do research in cohorts of animals that match more closely our clinical cohorts. We can pre-register our studies, and that would take care of a lot of the problems like outcome switching, which is also called hindsight bias, publication bias. It even protects authors from scooping. And in clinical medicine, this has actually worked quite well and led to a jump from actually a plummeting of positive results in the clinical literature because the authors couldn't switch the outcome afterwards or not publish it. We, I think, need to discriminate between exploration and confirmation, and what's meant by this is a lot of the papers that you read are confounding those both modes of exploration. They discover or come up with a hypothesis and at the same time prove the hypothesis. This is impossible. I mean, this is a logical impossibility. So you need to come up with a hypothesis and then independently, maybe even you yourself, but better someone else, needs to confirm it. And this is very rare, unfortunately, and I think we should do this. And there are now formats of even funding in the preclinical literature for preclinical studies. At least in Germany, we have that right now. And then I think we need to be ready for team science. I mean, this is what we do in clinical studies, but it's not done in preclinical studies, and I think this is a big problem. And it's doable. This is a study that we have done together with 5 groups. It increases the sample sizes. It makes results more robust. And these are true confirmations then. And there are European consortia that do things like this. I think this is something that is coming up. And finally, we need to publish our null results. Already the title null or negative is kind of, well, not so nice. But these are relevant results that need to be out there in the literature so that we do not double our efforts or are misled by findings that are sort of overblown or cannot be reproduced. So instead of a sort of a summary, I would ask you for a moment of self-reflection and in your different roles. We all have different roles. You may be an investigator in preclinical studies yourself, but you may just read the literature, or you may select grants as a reviewer, or you may review papers. So we all have these roles. And the question that I have to you is, where are you standing, or are you, if you just read it, if you read papers, is this list of things that I have here, is this something that you have in the back of your mind? Are you looking at whether the studies are randomized? What is the sample size? Has it been confirmed? What about the construct validity of what they are doing? My last statement regarding this should be, I think what is missing and maybe just sort of on the horizon, hopefully, is we need to incentivize these things. I mean, the problem, obviously, researchers are not stupid. I mean, you get a professorship for a Nature paper, and that needs to be spectacular, positive, and a mix of many, many things. And I'm not arguing against those papers. I have my own share of it. So, but we need this other stuff. We need robust studies. We need the null results and so forth. And we need to reward researchers, and young researchers should be able to make careers with this. Otherwise, we will never see it happen. So this is my last slide. If I was walking through a lot of stuff, so if you're interested at these slides and the quotes that are in there, I have posted it on Twitter, so you can download them. And I thank you very much for your attention.